Good morning and welcome again to another session for lectures at EHHI Institute. Today we are going to be talking about sepsis, and our guest on this program today is going to be Professor Isabel CORTZEE from Pretoria University in South Africa. And we would hear brief insights on what sepsis is actually and how we are going to diagnose sepsis and how do we manage sepsis. So, Professor Isabel, you are welcome.
Thank you very much.
So, we are keen that you have been teaching sepsis these past hours, and we want to get very clearly from you what are the key messages about sepsis that we need to retain, that we can tell others, that we can share with people in the community. First, please, can you kindly tell us what is sepsis?
Thank you very much. Yes, I think it's very important for us to understand the definition of sepsis, because that will also help clinicians then to diagnose sepsis and to manage it effectively. So basically, sepsis is the state of the body that is caused by the presence of an invading microorganism and the associated toxins in either through the blood or through tissues. So basically we can say it's a systemic state generated by the presence of an invading organism and the toxins that they release in the system. Thank you.
All right, thank you so much. As we have heard from her, she has tried to put the definition of sepsis in a simple way that everyone can understand. And now we are wondering if we really would want people to know more about how they can recognize that someone has sepsis. How can you put down this message in such a way that everybody can understand how to recognize sepsis?
Thank you very much. Yes, I think that is also very, very important, because most of the time sepsis is a clinical diagnosis. So almost the most important thing is we have to start with the history of the patient. So when we take the patient's history, already from the history, there will be some indication to us that this patient was exposed to an infection, maybe the patient had a surgical procedure, or the patient had trauma, or anything that in the history can relate to us to indicate some form of infection. So that is where we start. So with the history, so that's why we say if there's a positive history of any suspicion of an infection, then already that patient, we must actually red flag that patient. Then also clinically, we're going to see when we further do a systematic assessment. So when we look at the level of consciousness, we will also see that these patients already, when they are having sepsis, they will already show signs of a decreased level of consciousness. So when we assess the Glasgow Coma scale, we will usually see that the patient can already be confused or restless, so they already have a slight decrease in the level of consciousness. Then also very important, when we do the vital data of the patient, what we will see is that these patients will all present with a tachycardia. So the heart rate will usually be more than 100 beats per minute already. And if we measure the blood pressure, most of these patients will already have a hypotension. If they have sepsis or they're already in septic shock, they will present with a systolic pressure less than 100. Furthermore, we will also see that these patients at this stage will already have a decreased urinary output. So the output will be less than half to 1 milliliter per kilogram per hour. And that is already shown as signs of compensation, because when the blood pressure is low, the renal perfusion pressure is low, and therefore the patient will present with decreased urinary output. And then also very important that most of these patients will also present with severe pyrexia. So the temperature are usually more than 38 degrees, and we've seen some patients already having temperatures of 39 and 40 degrees Celsius. So that will also indicate to us that these patients are in septic shock. And then additionally to that, some patients can already, or most of the patients will already hyperventilate, and that can be due to two reasons. So the one reason can be they will hyperventilate trying to normalize the pH because they already have signs of metabolic acidosis, and other patients can already show signs of respiratory distress. So all of these clinical signs with this positive history of some infection or a suspicion of infection will then confirm to us that this patient is at risk for septic shock. Thank you, Daniel.
Thank you so much for those insights to how we can diagnose sepsis. It is quite interesting that once we suspect an infection and we confirm that there are some deterioration in the patient's physiologic parameters like the vital signs that she talked about, the respiratory rate, the heart rate, the blood pressure, and mental status. These are very, very important things that our nurses, our students, they have to know about this. And we are also keen to know from you. We have learned so much about the recommendations of the Global Sepsis Alliance, the African Sepsis Alliance, as far as management of sepsis in the world and in Africa particularly is concerned. And there are a lot of guidelines that talks about how we can recognize sepsis, how we can manage it. And I think one of these is always about a bundle, sepsis bundle. Professor Isabel, can you tell us again about sepsis bundle?
Thank you very much, Daniel. Yes, I think this is really a very important bundle, and the idea behind the bundle is that the bundle has got certain elements. So what they've tried to do is to put together 5 elements in this bundle, and if those 5 elements are implemented as a group or in a bundle, the outcome of the patient will significantly improve, and we then have a better patient outcome. So in this bundle, there's 5 elements, and I think the one thing that is very important is even if you are from a resource limited environment or in your healthcare setting, you don't have maybe the means to measure the lactate or to do a blood culture analysis, we still have to implement those elements, because later we might be able to send the blood away, and then at least we have those blood tests. So the first element is then for us is to measure the lactate level. So we draw a blood sample. So what we normally say, we need 2 samples. We need 1 sample for to measure the lactate level, because in these patients we already know the lactate level will be high. Because of this hypotension, there's not going to be enough pressure to give off oxygen to the tissues and the muscles. So the metabolism changes from aerobic in the presence of oxygen to anaerobic with limited oxygen, and that leads then to the formation of lactic acid. So this measuring the level of lactate also gives us indication of the patient's perfusion, but it also gives us an indication of the severity of the acidosis. And then simultaneously, we're also going to draw a blood culture. So as I indicated, even if you don't have the means immediately to send away this blood sample, it is very important for us to try and identify whether this patient's got a gram-positive or gram-negative bacterial infection, or maybe a fungus. So we need to analyze the blood. And in the same time, when we've done that, so that is the first element is then to measure the lactate. The second element is then to draw a blood culture. The third element is then to give the patient a broad spectrum antibiotic. So what we usually advise while you are what we do is we insert the intravenous line, and then once we've inserted the needle, we then draw the blood samples, then we connect the infusion line so that we can then give the patient a broad spectrum antibiotic. So that we must try to do within 1 hour from identification of sepsis. We have to give a broad spectrum antibiotic to try and cover most of the gram-positive and gram-negative bacteria. Then the fourth element is then that we can rapidly infuse crystalloids to the patient. So at this stage, especially as we indicated, one of the signs will be that the systolic pressure will be less than 100 milliliters of mercury. So we can then start the adult patient on 30 milliliters per kilogram per bolus of crystalloids. So there you can either use Rebus lactate or you can use saline, whatever crystalloid you have in your healthcare setting. We then give the patient that bolus to try and increase the circulatory volume so that we can increase the blood pressure to restore the cerebral, the renal and the peripheral perfusion pressure. And then the fifth element in this bundle is then Once we've given this rapid infusion of 30 milliliters per kilogram per bolus, if we then see that the systolic pressure is still less than 100, or if you are able to measure the mean arterial pressure, and if that is less than 65, then we have to add our drug of choice for this patient, which will then be the last element, is then the vasopressor. So our drug of choice here is noradrenaline, because that is going to work on, stimulate the alpha receptors to then increase the systemic vascular resistance, and in that way we will be able to increase the blood pressure. So in summary, if I can just summarize the 5 elements. So element number 1 is to measure the lactate level. Element number 2 is to draw a blood culture. Element number 3 is to give the patient a broad spectrum antibiotic. Element 4 is then a rapid infusion of 30 milliliters per kilogram per hour of crystalloids. And then the last element is then to add a vasopressor, and our drug of choice there will be noradrenaline. And the aim is then, if we implement these 5 elements as a bundle, then the outcome of our patient should improve, or it will give the patient the best possible survival rate. Thank you very much.
Thank you, Professor Isabel. And I would be keen again to find out from you. We are in a low resource setting, and most of our hospitals, like the district hospitals, the health centers, they would not be able to do measurement of lactate levels. And yes, we have understood that the first step always is to collect the blood samples before we can proceed with any other thing like the administration of the tailored antibiotic. But now, if finally they are not able to measure the lactate levels, what would be your recommendation for really communities that are really far off from places where they can measure the lactate levels?
Yes, thank you, Daniel. I think that's a very important aspect. If you don't have the resources to measure the lactate level, it doesn't matter. We still manage those elements. So we will still give the patient fluid, because we know the lactate in any case will be elevated. When we have the measurement, it just gives us that guide of severity. So normally in the element they say if the lactate is more than 4 millimoles per liter, then we have to give the patient fluid of 30 mils per kilogram per bolus. But even if you're not able to measure the lactate, if the blood pressure is low and the patient's already having hypotension, we know the lactate will be high. So irrespective if they are able to measure the lactate level, we will still continue, we will still give the patient antibiotics, and definitely then the rapid fluid resuscitation, because that is a vital element. And unfortunately, a lot of the times we are not aggressive enough in our management of sepsis, and the patient's already having a low blood pressure, which means the cerebral, renal and peripheral perfusion will be poor. There's no perfusion to the vital organs, and we need to give the patient that volume, even if we're not able to measure the lactate level. Thank you.
Thank you so much, and I think this is really very important information to nurses, physicians who are practicing in far-off communities to know, and very important. Always remember, even when you are not able to measure the lactate levels, continue to do the bundle, but check always fluid volume excess by auscultation, which you taught them already, I know. So we always have to keep doing these things, and let's try to see if we can be able to implement this kind of bundles in our settings. And thank you so much for this short episode, and we shall be inviting your students that you taught the past weeks to tell us what they learned, to be sure if the message that you are giving now is going through to the communities. So in our next session, we want to know from the students that you have taught if they have understood what you just told us here. Thank you so much.
Thank you very much.